Hello, everyone. On behalf of the Alliance for Regenerative Rehabilitation Research and Training and the International Consortium for Regenerative Rehab, I would like to welcome you all to today's Rising Star seminar presentation. Today, we are very fortunate to have with us Dr. Karina Nakayama, who will be giving our main talk as part of the Rising Stars seminar series. And we also have with us Mr. Hideki Kawai, who was a winner of our Lightning Talks series, Lightning Talks competition. With that, I would like to hand over to Mr. Hideki Kawai, who will be presenting a talk which is titled Optimization of Rehabilitation for Further Progress in Peripheral Nerve Regeneration. Hideki is a PhD student at Kyoto University, and his major is Human Health Sciences. He is also a research fellow of Japan Society for Promotion of Science and studies peripheral nerve regeneration. Congratulations, Hideki, once again on winning the Lightning Talk competition. And with that, I'll hand over to you. Thank you.
Yes, thank you for my introduction. I'll share my screen. It's my honor to be invited here as Writing Talk speaker. Today, I'm going to introduce our studies about optimization of rehabilitation for peripheral nerve regeneration. Peripheral nerves are tissues which connect brain to limbs and organs. Damages to peripheral nerve cause motor functional disorder and reduce patient's quality of life. Peripheral nerves have intrinsic regeneration abilities, but their regeneration rates are very slow. Long-term denervation causes degeneration of neuromuscular junction and muscle atrophy, and results in poor functional recovery. So approaches to promote peripheral nerve regeneration need to be developed. Autologous nerve grafting, outgraft, is the gold standard treatment for peripheral nerve injury, but there are several problems such as donor site dysfunction and limited supply of nerve graft. Several artificial nerve conduits have been developed to overcome the problems with outgraft. Cell transplantation is an approach to promote peripheral nerve regeneration. Also, rehabilitation, such as electric stimulation, ultrasound stimulation, and exercise are other approaches to promote peripheral nerve regeneration. Some preclinical studies confirm the additive effects of cell transplantation and rehabilitation. This slide shows a preclinical study which combines cell transplantation and rehabilitation. As rehabilitation, ultrasound, electricity, laser, auto shortwave, magnetic field, and exercise were used. And as graft cells, iPS cells-derived neural stem cells, Schwann cells, ES cells-derived neural crest stem cells, mesenchymal stem cells, and bone marrow stromal cells were used. As this table shows, many kinds of cells and rehabilitation were used and combined to promote peripheral nerve regeneration. We study peripheral nerve regeneration using ultrasound stimulation. Ultrasound can be applied on injury tissues non-invasively and painlessly. Ultrasound is used as a therapeutic modality for many kinds of tissues like bone and soft tissues. The effect of ultrasound for peripheral nerve regeneration are confirmed in meta-analytic study in preclinical models. Ultrasound can enhance transfer variability and proliferation, and also upregulate neurotrophic factors such as brain-derived neurotrophic factors, and ultrasound promote peripheral nerve regeneration and motor functional recovery, as shown in meta-analysis. Ultrasound is expected as a therapeutic modality, but there are several problems. Ultrasound can promote peripheral nerve regeneration when combined with cell transplantation. However, the results of combination therapy were inferior to that of autograft. In addition, optimal ultrasound parameters are unknown. In order to attain further regeneration, we need to optimize rehabilitation. So we investigated the optimal intensity and initiation time of ultrasound therapy. First, we investigated the optimal intensity. We made sciatic nerve crush injury in rats using a needle holder and applied ultrasound. Ultrasound was applied on the skin above the injury site through a coupling gel, and we compared intensity of 30, 140, and 250 milliwatt per centimeter square. And we used pulsed ultrasound to get non-thermal effect of ultrasound. These are tracing blue stained sections. After 3 weeks after injury, we evaluated myelinated fiber density, and the density of 140 was significantly higher than sham-stimulated group. Based on this result and as a result, we concluded that 140 was the optimal intensity. Next, we investigated the optimal initiation time of ultrasound therapy. This is a time course of peripheral nerve regeneration. After peripheral nerves are injured, inflammation responses occur. Immune cells like neutrophils and macrophages are infiltrated into the injury site, and the axons and myelin cells distal to the injury site are broken down and removed. This process is called Wallerian degeneration and establishes a microenvironment for peripheral nerve regeneration. After that, axonal elongation and myelination occur, and peripheral nerves are reconstructed. Our previous study revealed that ultrasound can suppress inflammation, and other studies reported that ultrasound can moderate macrophage phenotype from pro-inflammation type to anti-inflammation type, and also accelerate Wallerian degeneration. These results indicate that ultrasound therapy in the early phase after injury must be essential. So we investigate the optimal initiation time of ultrasound therapy. We made sciatic nerve crush injury again and divided into 4 groups, which received ultrasound therapy 1 day, 7 days, and 14 days after injury, or sham stimulation for 4 weeks. And we applied on the skin above the injured site, and we used intensity of 140 based on previous study. This slide shows the result of electrophysiology for weeks after injury. We stimulated proximal to the injury site and recorded compound muscular action potential at gastrocnemius and recorded evaluated amplitude. The result of the amplitude of 1D group was significantly higher than sham-stimulated groups. And this slide shows the result of histomorphometry 4 weeks after injury. We obtained the images using transmission electron microscopy and evaluated myelin-6 thickness. Myelin-6 thickness in 1D group was significantly higher than in other groups. These results indicate that ultrasound therapy initiated 1 day after injury promoted maximal regeneration. We also performed 3-dimensional motion analysis as a motion functional analysis. And we evaluate joint angle during treadmill walking. We performed motor functional analysis each week after injury, but we didn't observe no significant differences affected by ultrasound in this experiment. In summary, we investigated optimal ultrasound intensity and initiation time, and revealed that intensity of 140 and ultrasound therapy initiated 1 day after injury promoted maximal regeneration. In the experiment of investigation of optimal initiation time, we didn't observe significant improvement. So additional conditions of ultrasound therapy need to be considered to promote further regeneration. Thank you for listening.
Thank you so much, Hideki. That was a wonderful talk. We have some time for questions. Attendees, you may please use the Q&A option to ask your questions. I think you may also use the chat box for questions. Caitlin, am I right that they can also use the chat box for questions?
Yes.
Okay. So while people are thinking of questions, I will get things started for the Q&A. Hideki, in terms of mechanism, what do you think might be going on that is promoting better recovery of the nerve with ultrasound therapy?
Oh, the mechanism of ultrasound. Okay. Oh, one. Okay. Oh, one mechanism is that ultrasound can induce mechanical stress, and cells like macrophages have mechanosensitive receptor, and ultrasound can moderate the expression of macrophages or other cells, and they can promote peripheral regeneration. Ooh. And also, we previously revealed that ultrasound can promote axonal elongation for 14 days after surgery. So ultrasound can accelerate peripheral regeneration and reinnervation, and it can promote peripheral regeneration, I think.
Thank you, Hideki. Very, very well answered. Thank you so much. Um, Dr. Fabrizio Ambrosio says, great job, Hideki. So nice to see the intensity and dosing studies. In future, I understand that you plan to evaluate a combination of stem cell therapy and ultrasound. Do you have ideas of how the timing of cell transplantation may coincide with initiation of the ultrasound protocol?
Oh, 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 you mean that? Mm, oh, you it mean that when cell transplantation, when should we intervention if combined with cell transplantation?
Yes,
Right?
I think that is what
Oh,
Dr. Ambrosio
oh,
meant. Yes, please go ahead.
oh. If the graft cell is non-injured cells, so the effect of ultrasound might difficult to injured tissues or the graft cells. But ultrasound can enhance cell ultrasound can cell viability. So from ultrasound therapy initiated early after cell transplantation may be essential.
So, thank you, Hideki. I think would it be right to say that ultrasound therapy after initiating ultrasound therapy after cell transplantation would be most appropriate?
Please say that again.
Would it be right to conclude that your opinion is that initiating ultrasound therapy sometime after cell therapy would be most appropriate in your opinion?
Yeah, in my opinion.
Okay, all right.
Yeah.
Thank you so much, Hideki. Much appreciated. Great talk. Very nice slides. And again, I too agree with Dr. Ambrosio that the kind of dosing studies that you did prior to applying it in your preclinical type study was very appropriate. It kind of is in keeping with how we should do like pharmacological studies. So well done. Thank you. And congratulations again on being a winner of the Lightning Talk competition.
Thank you.
All right. All right, we will move on to our main talk for today, the Rising Stars talk. We are very fortunate to have with us Dr. Karina Nakayama, who is an assistant professor in the Department of Biomedical Engineering at Oregon Health and Science University. Dr. Nakayama's lab develops regenerative and immunomodulatory biomaterials to enhance engineered vasculature, muscle, and complex multi-tissue composites to develop therapies for ischemic cardiovascular disease and traumatic musculoskeletal diseases. Dr. Nakayama completed her PhD at UC Davis and then went on to do a postdoc at Stanford University. Her talk today is titled Patterned Scaffolds and Running Exercise for the Treatment of Musculoskeletal Trauma. Thank you, Dr. Nakayama, for making time to share your data and insights with us. And I will now hand over to you. Thank you.
Thank you so much, Joseph, for the introduction, and thank you to the AR3T community for the invite to present today. And so, yeah, I'm really excited to be here. And we're going to talk about how pattern scaffolds can be combined with running exercise for the treatment of musculoskeletal trauma. So I thought first I would just provide a brief introduction into our lab. So I am an assistant professor in biomedical engineering at Oregon Health and Science University, or OHSU. So this is our group and our lab, which is located at the Center for Health and Healing at the South Waterfront campus at OHSU. So we started out as a group of 4, as you can see here in our very COVID appropriate lab photo. And then we'll be roughly doubling in size in a couple of weeks. Starting this summer, we have 4 new lab members. So we'll be a total group of 8. So our group works on the development of engineered therapeutics using translational and rehabilitative animal models for the study and treatment of musculoskeletal traumas. And so for the talk today, I'll be sharing with you some background on the field of skeletal muscle engineering and regenerative rehabilitation and how our lab uses these integrative concepts to advance muscle healing. So I wanted to first start by just providing a broad overview of the concepts that are used in all of the research themes within our lab group. So our research in our group bridges tissue engineering with regenerative medicine and rehabilitative science with the overall goal of repairing or replacing tissues that were lost to injury, disease, or even aging. So through our work, we hope to be able to gain a better understanding of the musculoskeletal niche and to better accommodate and maximize the potential of novel regenerative approaches. And so the concept of engineering the response to cells and tissues to biophysical stimuli has long been the scientific basis for regenerative biomedical engineering. So every single cell in the body naturally experiences some kind of mechanical force or dynamic force, whether that's due to tensile or compressive stresses, shear strain, and electrical stimuli. And this just happens naturally. And this can be due to hydrostatic pressures, bioelectrical signals, and as I mentioned, just like compressive forces. And so endogenous cells and tissues, they normally experience these biophysical forces, and this actually helps guide tissue remodeling, repair, and ultimately healing. And so therefore it makes sense that the application of rehabilitation protocols can ultimately promote functional tissue recovery after an injury. And so following surgery or injury, or just in the setting of disease, physical therapy and rehabilitation medicine are often prescribed to accelerate and enhance healing outcomes. And so this is really common practice in the setting of neurologic and neuromuscular and musculoskeletal injuries, primarily due to the link with mechanical and electrical properties. And so rehabilitation can be applied in the form of tissue loading, conditioning, stretching for the application of tensile forces, electrical stimulation, manual therapy such as joint mobilization, ultrasound, and modulation of tissue temperature through icing or heat exposure. So the ultimate goal of a lot of these therapies is to strengthen the remaining tissue and to restore joint range of motion. It also helps to modulate physiologically the immune response, as well as the release of local growth factors that can also help to promote vascularization of the tissue. And so as the final research talk in this regenerative rehabilitation series, today I will be describing our combinatorial biomaterial-based approaches for regenerating skeletal muscle and how we can combine 3D scaffolds that exhibit nanoscale patterning with rehabilitative exercise in order to enhance the host response to injury. And so to begin with, so skeletal muscle is a very privileged organ in its remarkable ability to self-repair. So in contrast to other tissues, injured skeletal muscle has this amazing intrinsic capacity to adapt and initiate a synchronized biological response to prevent further muscle loss and eventually lead to regeneration. And so minor injuries such as muscle strains and contusions will heal spontaneously in healthy adults. So as we exercise, we build new muscle, we recover from the exhaustive workout, and are usually stronger from the process. And this is just an intrinsic mechanism that our body naturally has to be able to repair muscle. And so the process of normal healing in response to minor injuries involves the activation of these resident muscle stem cells, or also known as satellite cells, which normally reside in the adult muscle in the quiescent state in the muscle myofibers. However, following injury or a workout, a severe workout, they can become activated and begin to proliferate, and they undergo changes in their cytoskeletal organization and shape. And they enter into this precursor stage as a myoblast or myocyte. And then within a few days, these myocytes have fused to form these multinucleated myotubes that then further mature into myofibers. And those are the primary contractile units of skeletal muscle. But what we want to explore is what happens when these native programs don't work as intended or simply cannot outpace fibrosis. And so in some cases, the injury to skeletal muscle is so extensive that the normal healing programs cannot regenerate the damaged tissue in place of new myofibers, is non-functional scar tissue. And this is a condition that's known as volumetric muscle loss. So you have a loss of muscle that is non-functional and replaced with this fibrotic scar tissue. And so this condition is also known as VML. So VML injury consists of extensive fibrosis in the injured muscle and is associated with a reduction in muscle strength and joint range of motion. So current approaches for treating VML in the clinic include scar tissue debridement, which just involves the removal of non-viable or infected tissue or any foreign materials that might have contaminated the area. And debridement is often also coupled with free functional muscle transfer, in which a muscle from another part of the body is excised and then transplanted into the site of injury. So despite these advancements in overall limb salvage efforts, the mediation of VML injury is still associated with extensive donor site morbidity, graft failure, and may be limited by the availability of healthy muscle. So one regenerative approach that has the potential to circumvent these challenges is the application of off-the-shelf biomaterials that possess the ability to restore both tissue structure as well as function. And so given the complexity of biological tissues, strategic biomimicry through the thoughtful pairing of cells with bioactive scaffolds and biomechanical environments enables the recapitulation of the physiologic structure-function relationship and advances this pathway towards clinical translation. And so to regenerate skeletal muscle, we can look at the template that nature has provided us. So muscle tissue is comprised of highly aligned, highly oriented myofibers that coalesce into these also aligned functional units. And alongside the myofibers is an extensive vascular network that helps to support the high oxygen consumption and high metabolic rate of the skeletal muscle. And so the choice of materials for engineering skeletal muscle is pretty broad, and pretty much the full gamut of natural materials and synthetic materials have been explored by other groups. So our group was primarily interested in the use of natural materials due to their biophysical properties that closely resemble that of native muscle tissue. So some example of natural materials are alginate, collagen, fibrin, and also decellularized ECM. And so our group mostly works with collagen and then decellularized ECM. But today I'll be talking about our collagen work. And some of the advantages to using these natural materials is that they have a stiffness that is in the range that's pretty close to muscle. So they have a native, mechanical properties that are pretty similar. They also have some endogenous growth factors that can be released to help promote regeneration. Both collagen and fibrin have pretty good architectural control. And then they also naturally possess the ligands that would be needed for cell adhesion. So there's no additional conjugation of like RGD or other peptides that are required to be able to enhance cell attachment. But there are some disadvantages, like with all materials, such as it is a little bit difficult to control their degradation rate, and there's still immunogenicity concerns with the use of these natural materials. And so, as I mentioned earlier, we chose to use a collagen scaffold. And so in terms of the native composition of skeletal muscle, the tissue contains a wide range of collagens that pretty much predominate with collagens type 1 and 3. And those align into an array to form those fibrils that I mentioned a couple slides back in native tissue. So we decided to use collagen type 1 as our primary biomaterial for skeletal muscle regeneration. And so we have actually previously reported the fabrication of patterned collagen scaffolds with nanoscale features that are capable of directing and guiding the cell cytoskeletal organization. And so these scaffolds are fabricated using a shear-based extrusion approach, in which we take monomeric high concentration collagen and we extrude it at a high velocity into a neutralizing buffer to initiate fibrillogenesis along the direction of the extrusion. So this creates these highly aligned, highly oriented fibers that are on the order of around 30 to 50 nanometers in diameter. And so similarly, we're also able to create randomly oriented fibers that are made from the same material, but by just slowing down the extrusion process, these fibers come out with a random orientation. And then when seated with cells, these scaffolds guide the cell cytoskeletal organization along the direction of the fibers. So if they are aligned fibers, then the cells align along that same direction. And if they're randomly oriented fibers, then we see a random orientation of those cells that have been seeded. And we've seeded a wide range of cells that range from ECs to iPSC, ECs, cardiomyocytes, fibroblasts, smooth muscle cells, and myogenic cells. And so the ability of scaffold patterning to control cell behavior has a decade-long history or more. And our group actually started out by using pattern scaffolds to modulate angiogenesis in the ischemic hindlimb. So I just wanted to highlight a previous study that was done by our group where we did take aligned scaffolds, we seeded them with ECs and transplanted them into a ligated femoral artery. So this is a hindlimb ischemia model in the mouse. And what we did was we showed that when we have aligned scaffolds that were transplanted with cells into this ischemic environment, we were able to restore both perfusion as well as arteriogenesis in the hind limb of these mice. And so the ability to be able to control cell shape and our proof of concept of the fact that we can use these scaffolds to also orient myogenic cells bodes really well for skeletal muscle engineering, which is a highly oriented muscle that we were going to try to mimic. And so what we did here is that we wanted to see the contribution of patterning as well as co-culture to creating an engineered skeletal muscle in vitro. And so we have both randomly oriented and aligned scaffolds and seeded those with myogenic cells as well as endothelial cells. And with our scaffolds, we have shown that pattern topography guides myogenic differentiation as well as fusion efficiency and also the maturation of myotubes in vitro. And then we have also shown that topography dependent improvements in both the maximum contraction velocity as well as the total contractile area upon electrical stimulation. So on the right-hand side, we have the aligned scaffold that is contracting in this movie. And then on the left-hand side, it looks like it's not really doing anything, but this is a movie as well. The randomly oriented scaffold on the far left is also being paced electrically at the same rate, but there is far less overall contraction. The overall magnitude is a lot more attenuated in the random scaffold compared to our aligned scaffold, which has a much more robust contraction. It's unidirectional. And overall, the entire area is contracting in the same fashion. And so that was super promising. And then also looking in terms of the gene expression profile, as well as the proteomic profile, we did both RNA-seq and a proteomic array to see what was going on within these scaffolds and saw that there is, as expected, an increase in myogenic genes, angiogenic genes, and oxidative phosphorylation. And overall, just there was an increase in both myogenic cytokine production and angiogenic cytokine production when we had aligned scaffolds compared to randomly oriented scaffolds. And so in order to assess the therapeutic potential of our scaffolds in a muscle injury model, we used a mouse model of VML that was previously developed by our collaborators at Stanford. And so the pathological features of VML were replicated by the surgical ablation of a defined mass in the TA muscles. This is approximately 20%. Depending upon the study, it will range between 20 to 30%. So the actual volume of this is 7 millimeters in length by 2 by 3 millimeters. And so following the ablation of the set volume in the TA muscle, there is no recovery of muscle mass, and in place of the muscle that has been removed, which is outlined here in, by the dotted line, there is only fibrotic scar tissue that replaces this muscle, and there is no recovery of muscle force either. And so in subsequent studies, we transplanted cell-seeded pattern scaffolds into the site of injury in our VML mouse model to assess muscle regeneration as well as graft integration. And so we demonstrated improvements in myogenesis as well as angiogenesis when we had aligned pattern scaffolds transplanted with both myogenic and endothelial cells compared with scaffolds that had a random orientation. And this really highlights the importance of scaffold topography and modulating tissue regeneration. However, a translational limitation of this approach is cell source availability. So to tackle this challenge, our next step was to engineer a cell-free scaffold that could be paired with a comprehensive physical rehabilitation program in the mouse to enhance tissue regeneration without the need for transplanted cells. So we had a feeling that our findings with topography would be impactful, but based off of some pilot studies, we did not think that just by transplanting the scaffolds alone without any cells, that would be sufficient for regeneration. And so we wanted to pair it and couple it with an exercise regimen to be able to have a synergistic effect to hopefully enhance the regeneration of acellular scaffolds with exercise in the injury model. And so there are many benefits to a well-crafted physical rehabilitation regimen. So physical exercise stimulates vascular flow and angiogenesis. It regulates the activation of muscle satellite cells and also stimulates ECM remodeling. Additionally, cyclic mechanical stretch induces the production of myogenic growth factors such as IGF-1. So the IGF gene is normally activated in response to mechanical stimulation that's produced by repeated cyclic stretch without normal cycles of tension and stretch. This pathway just sits inactive, leading to muscle atrophy, and therefore also underscores the importance of physical exercise in muscle health and healing. And as we have surgeries or recover from an injury, this is the time period when there's usually a lot of rest and inactivity. So this is a time period when our bodies are not naturally producing as many of these mechanically regulated growth factors such as IGF-1. And so therefore, in the study that I am going to highlight today, we hypothesized that an exercise regimen combined with an acellular pattern scaffold with the IGF-1 growth factor could provide a translational and off-the-shelf regenerative approach for the treatment of VML. And so during initial pilot studies, we explored different forms of exercise that ranged from free running in activity wheels to forced treadmill. And so both were associated with a wide range of pros and cons, such as dose control, stress response, and runner activity level normalization. But we ended up going with the activity wheels, which would allow tracking of individual running patterns, and as well as based off of our pilot histological assessments of initial tissue regeneration, this appeared to be the most promising route. So from here on out, we went with the activity running wheels. So in the design of our study, it was important that certain aspects of the translational feasibility be considered. So for example, our scaffold is acellular and exhibits the same aligned topography that we had previously demonstrated in some of the studies that I highlighted from our group earlier, and that enhanced myogenesis as well as angiogenesis. And then secondly, we incorporated exercise in the form of activity running wheels to stimulate blood flow and satellite cell activation. However, many patients, as I mentioned, following surgery or injury are unable to exercise. And so pilot studies showed negative remodeling and fibrosis in our VML model if exercise was actually introduced too early. And this is actually pretty consistent with other musculoskeletal injuries, that the timing of exercise is actually pretty important. And so therefore, we use an exercise regimen that begins 7 days following initial VML injury and lasts for 14 days for a total of 21 days from injury to final assessment. So we gave them that initial rest period of 7 days where they were not allowed to run on the running wheels. And this allows us to also influence the homeostatic programs that are initiated during the initial rest period following injury by delivery of IGF-1. And so this was the rationale for incorporating IGF-1. As I mentioned earlier, IGF-1 is mechanically stimulated. And so during that rest period, IGF-1 wouldn't normally be as stimulated as if they were able to do a regular rehabilitation regimen immediately following injury. And so this kind of bridges that period by providing this mechanically stimulated IGF-1 in a dose form incorporated into the scaffold during that initial 7-day period of rest and recovery that otherwise would not have exercise. And so it's kind of a threefold treatment. We have both the scaffold topography, as well as the IGF-1 delivery, as well as our exercise. And so our patterned 3D scaffolds were fabricated as in our previous studies. So shown here on the left by SEM imaging, it highlights the aligned orientation of the collagen fibers. And also we showed that there is a cumulative release of IGF-1 over the course of 21 days, and this is quantified by ELISA. And we had a total release of 1,250 nanograms of IGF-1 with a burst effect occurring within the first 24 hours, but that was actually beneficial in the sense that we wanted to have most of the IGF released in the initial rest recovery period of those first 7 days. And so then to test the bioactivity of IGF-1 releasing scaffolds, we first did some in vitro studies. So we looked at myotube formation and the capacity of these myoblasts to form myotubes was quantified. And then we saw that on the IGF-1 releasing scaffolds that were seeded with myoblasts, this resulted in myotubes that were approximately 1.5-fold longer in length and contained 2-fold greater nuclei per myotube when compared to scaffolds without the IGF-1. So when implanted into the ablated TA muscle, we observed greater de novo formation of myofibers, a 2-fold increase in the abundance of mature neuromuscular junctions, and a 3-fold increase in the density of perfused microvessels in animals that were treated with the IGF-1 laden scaffolds, coupled with exercise, compared to the controlled scaffolds that were transplanted into mice that did not receive exercise. And so this suggests a modulatory role of both IGF-1 as well as exercise in these regenerative outcomes. And so in summary, in the current study, the spatially patterned aligned topography of our engineered scaffolds serve to both control cytoskeletal interactions through nanoscale guidance cues that directed cell orientation, as well as organization along the longitudinal anatomy of the muscle. And the incorporation of IGF-1 into scaffolds serve to stimulate proliferation, as well as initiation of myogenic fusion of skeletal muscle myoblasts in vitro, and likely aided in the activation of resident stem cells and also the recruitment of endogenous endothelial cells to the scaffold and injury site. So taken together, we have shown that through combined transplantation of patterned biomaterials with mechanical stimulation in the form of voluntary running exercise, that large volumetric skeletal muscle defects in mice can be regenerated as well as reinnervated to an extent that is comparable with native tissue. And so I just wanted to kind of end by bringing this full circle to what our lab is actively working on for the past 6 months. So during the past 6 months, our group has been working on new engineered approaches to be able to control and enhance the regeneration of muscle and bone tissues that have been damaged due to extremity trauma. So these injuries are common in both the civilian and military population and present as an open fracture in the bone and also concomitant with soft tissue damage. And so these kinds of injuries result in a very delayed bone union. So it's 4 to 5 times more likely to not result in bone union when there's also severe muscle and tissue damage associated with an open fracture. And so 40% of these patients manifest severe disability. And so while there are efforts for limb salvage, these efforts are still fall short of a long-term rehabilitative benefit to these patients. And so this is where we kind of want to use our knowledge that we have in regenerating skeletal muscle and apply it to this two-tissue injury model. And so the idea is that we know that there is a connection between muscle injury, bone injury, and muscle and bone healing. We know that bone doesn't heal as well when there's also muscle injury. And that largely for historical reasons, people have thought that this was largely due to vasculature, but there's been a lot of studies recently that have suggested that there is actually a contribution of muscle cells and muscle cytokines that are actually contributing to determining whether or not the bone can heal more efficiently and effectively. And so for our most recent projects, we have been looking at developing a model of this composite injury in the mouse TA and tibialis anterior. So all of our muscle injuries previously were in the tibialis anterior, so the TA muscle. And so then for this model, we also coupled that with a bone injury, and that's going to be an adjacent bone, the tibia. And so this is actually kind of an older image of the surgical model that we have now refined, and we're working on developing a custom plate to allow for the curvature of that tibia bone. And the ultimate goal of this is to be able to use some of our engineered therapies that have worked with regenerating skeletal muscle and apply it to this model so that we focus on the healing of the muscle and then assess whether or not that contributes to enhanced healing of bone. And then alongside with that, we are also working on a rehabilitation regimen with using the activity wheels that we've used previously with our muscle injury studies in this composite injury model, and trying to figure out both the dose and the timing of the application of exercise. As I mentioned earlier, the timing is pretty important. If exercise is introduced too early, then you end up getting negative remodeling responses. So we're in the process of, as I mentioned, figuring out both the dose and the timing of that, and also applying progressive resistance as well to enhance both muscle and bone regeneration in our mouse model. And so to kind of bring everything full circle, these studies have shown that exercise programs can stimulate the donor-host interface to foster integration and promote a series of beneficial regenerative responses. So the combination of rehabilitation protocols with cell-based therapeutics can enhance transplantation efficiency and synergize with the host response to guide beneficial tissue remodeling and repair. But as I mentioned, excessive loading following injury or just implementation of exercise too early in the recovery process can trigger a cascade of deleterious consequences that worsen tissue dysfunction and can also impede recovery. So overall, though, there is a tremendous potential in the field of regenerative rehabilitation to be able to guide the development of targeted clinical rehabilitation programs that can permanently change the way that we approach regenerative medicine and engineer musculoskeletal tissues. And so with that, I'd like to thank all of our collaborators back at Stanford. Most of this work was done during my postdoc and instructorship over at Stanford, and then we've carried on some of that work as I've transferred to OHSU as an assistant professor. And so thank you to all of our new lab members also here at OHSU, especially Cynthia Alcazar, who played a critical role in the design and application of our translational animal injury models. And also thank you to our funding sources, especially AR3T, for their tremendous support throughout the years of these projects. And again, to the organizers for this opportunity to share our work. Thank you, and I'll be happy to take any questions.
Thank you so much, Karina. That was a fantastic talk. Almost, you know, an exemplar on how to give a great talk. So thank you so much for that. We welcome your questions. You may please feel free to use the chat or the Q&A option to ask your questions. While we wait, I'll just get things started. Karina, what do you think in terms of established VML, you know, where time has passed, the tissue has changed so much that, you know, you don't have a myogenic environment anymore, which will sort of provide cells for the scaffolds to incorporate. Do you think that maybe when this translates to a therapy for established VML, something might have to be done to kind of stimulate a myogenic environment, such as intentionally producing some level of muscle injury to the residual muscle?
Yeah, no, absolutely. And I mean, so all of the injury models that we did here, they were all acute. So on the same day as the injury, we did the transplantation of the therapies. Now others have done chronic injury models that definitely have a different kind of outcome, where the injury is created and then 30 days later, they go back in, reopen it, and then debride the scar tissue. So kind of an answer to one of your questions, you're absolutely right. So we do need to create some kind of muscle injury again. And that's kind of what's done by the scar tissue debridement that forms. And so that in itself creates kind of a new, less harsh injury, but it does to like stimulate, you know, blood cells and the infiltration of immune cells. And that's kind of also, I didn't talk too much about this side or aspect of our research, but we're really interested in what's happening on the immune side, because we think that that's a really large player in how the tissue ends up regenerating. That initial immune response, the infiltration of macrophages, how they polarize initially can really dictate which way the tissue goes, if that's going to be a pro-fibrotic or a pro-myogenic approach. So in terms of like some other cell types, absolutely, like controlling that initial cell response with some kind of additional injury is usually very stimulatory of being able to initiate a regenerative response. So just by itself, you know, with a stagnant injury, I think it would be a lot harder to initiate any kind of regeneration without the host contributing endogenous cells.
Thank you, Karina. We have a question that's come through the chat, and that's from Shruti. She asks, in your new direction, what factors are you considering other than IGF? Is the goal to heal bone and muscle simultaneously?
Yeah, so that's a great question. So in the bone muscle composite injury, so we're not actually using any growth factors. So we're hoping to not use it. So far, you know, pilot studies have been promising, but normally with bone regeneration, there's some kind of, you know, bone morphogenic protein that has to be incorporated to stimulate bone regeneration. But because our focus is on muscle, we really want to keep it as clean as possible. And so our goal is to try different biomaterials and cell combinations and exercise and rehabilitation methods to focus on the muscle healing and then observe how it then heals bone. So our focus isn't as much on like a bone biomaterial and the growth factors that would be needed to heal bone, but our main hypothesis that is driving a lot of our composite injury studies is that if we heal the muscle better, we're going to, as a default, end up healing bone better.
Thank you. Any other questions from the audience? Since we have a few more minutes, I will ask one more question. One of the problems that we have with mammalian skeletal muscle is the lack of ability to undergo hyperplasia. Hypertrophy happens, but hyperplasia does not. And to some extent, when we expect the residual muscle to sort of contribute to a scaffold, we are kind of hoping that, you know, we would get something akin to hyperplasia. This is just a kind of an open question. How do we get the residual muscle to sort of say, okay, now I can expand into this new scaffold that has been provided to me?
Yeah, no, absolutely. So we haven't specifically looked at like how to target hyperplasia as opposed to hypertrophy. But one thing that we did notice when we had the transplantation of cells, and that was when we showed where we transplanted with both myogenic cells and endothelial cells, is we did get a lot of connecting up of the endogenous myofibers and the endogenous vasculature infiltrating into the scaffold. And they integrated really well, where we were actually able to show, like, so our myogenic cells were GFP positive, and we transplanted those so we could kind of track the contribution of our transplanted cells versus the endogenous cells. And so we saw a lot of hybrid myofibers that had formed, indicating that we had GFP positive and GFP negative myofibers like within the same myofiber. So it indicated that there was some endogenous cells that were contributing into the scaffold, infiltrating, forming, and fusing with our transplanted cells. So these would be more de novo myofibers that had formed. And so that really indicated that, you know, the cell transplants were effective in creating new de novo myofibers. And then a lot of our vascularization, we do think, though, was largely from the host environment kind of infiltrating and coming into the scaffold, rather than the cells that we transplanted producing angiogenesis and then growing outward. But that being said, we did see some, you know, de novo formation of, you know, new myofibers when we had cells transplanted. So I think that when we had our acellular scaffolds, we didn't have the cells, so we couldn't quite see that same metric. But most likely, it is going to be quite the challenge. It's going to require some additional growth factors or some really tailored rehabilitation regimens to combine with several different bioengineered therapeutics in order to really create that ideal regenerated muscle that is going to go beyond just hypertrophy.
Wonderful. Thank you so much. I don't see any other questions, so I guess we can wrap up. I would like to once again thank you, Dr. Nakayama, as well as our lightning talk competition winner, Dr. Hideki Kawai. Thank you so much for making time to speak with us today, share your data, your insights. And I also would like to thank the audience once again for making time to attend today's program. With that, I wish you all a very happy summer, winter, whatever it is in your part of the world. Be safe, be well, take care.
Thank you so much.